Great. Thank you, Brian. Thank you, everyone, today for showing up so early in the morning. And thanks, Sheila, for the opportunity to speak at the Grand Round today. So today, we're going to talk about the point-of-care viscoelastic testing of that in preoperative coagulation and patient blood management. And I have no disclosure. And this is the learning objective for today's talk. So the viscoelastic testing. Viscoelastic testing of it is a form of hemostatic analysis that examines the ex vivo transition of the whole blood from the liquid state into the gel state as it occurs during the clotting as real time. It is a form of coagulation analysis. The viscoelastic test system has several systems in the platform, and many of them are considered the point-of-care testing. So viscoelastic test is based on the principle that the whole blood is clotting. And as it clots, it gains elasticity in the blood, and the blood clots become stiffer and resist to deformation. By measuring the stiffness, or what we call the shear modulus, then we can analyze the clot stiffness of the blood. So there are several ways that we can measure the blood clot stiffness. So this is the first and the most common method, which is a cup and pin method. That there are two systems that use this technique. First is thromboelastography or TEG, and the second one is thromboelastometry or ROTEM. So the pin is dropped inside the blood and detect the clot stiffness as the clot is forming. The TEG uses a stationary pin with oscillating cup, and the ROTEM just uses a stationary cup with oscillating pin. The second and newer technique is harmonic resonance assessment, which are used in the TEG6 and the Quanta system. So as the clot is forming, it reacts to the light or the ultrasound waveform and create the different harmonic frequency, which are detected and analyzed into the clot firmness. So this is the example of thromboelastography or the TEG graph. So in the graph, there are three distinct periods of interest during the clot formation. The first part is the clot initiation, which represented by the R time. The second part is the clot formation and polymerization, which represented by the K time, alpha angle, and the maximum amplitude of the MA. And the last part is for the clot lysis or fibrinolysis, which represented by the LY30 value. Thromboelastometry or TEG parameters also generate the equivalent graph and parameters, but with a different nomenclature, such as clotting time or CT, clot formation time or CFT, and the maximum clot firmness or MCF. So the bed parameter represent coagulation system in the four main areas. The first one is clot initiation, which representing the coagulation factors. The second one is the clot kinetics or propagation, representing the fibrinogen and or the platelets. The third one is the clot strength, which represent the platelets and the fibrinogen combination. And the fourth one is clot stability, which representing the fibrinolysis. So despite the traditional interpretation that the clot kinetic value represent only fibrinogen and the clot strength that represent only platelets, but in reality, both are affected by the platelet and fibrinogen contribution. As this study that published in 2014 showing that the clot strength is a factor of both platelets and fibrinogen. When measuring the clot strength, the fibrinogen was contributing up to 43% of the total clot strength or MA or the MCF in TEG and the ROTEM system. So how do we know what are the real cause of coagulopathy? By using the viscoelastic test. And this question has generated a variation of viscoelastic test by adding various activators and inhibitors. For example, in this picture, for the INTEM or the TEG, the test uses kaolin to activate factor 12 to assess the intrinsic pathway. For the XTEM uses tissue factor to assess the extrinsic pathway. And for the rapid TEG, uses the thrombin to directly assess fibrin and the platelet function and bypass both extrinsic and intrinsic pathway. So these are the variation of the TEG testing available in the market. For example, by adding the heparinase it allows the test to eliminate the heparin effect, and normalization of the test could actually represent the systemic heparinization, or the adding the abscesimab, which is a platelet inhibitor, will reveal the true fibrinogen contribution to the clot firmness. The ROTEM also uses a similar principle, but with the different reagents to achieve the same purposes: to detect heparin effect, to elicit the fibrinogen-only contribution, or the proof of fibrinolysis. And with this test variation, the vet can detect and differentiate the causes of coagulopathy. So interpretation of that could be confusing at first. So here are some examples how to use the test variation to help our interpretation. The first example is, for example, when there is a prolongation of the clot initiation time represented by the prolonged R time or the CT time, adding the heparinase will eliminate heparin effect and show the coagulation status without the heparin. And the normalization of the test result will confirm the pure heparin effect. The second example is when the clot strength represented by MA or MCF is reduced, direct measurement of fibrinogen function will help differentiate between the low fibrinogen or low platelet counts. Now, let's talk about the standard plasma-based laboratory coagulation test, or the SLT, that we use most of the time and every day. So as we all memorize this diagram during the medical school, it is a traditional coagulation pathway, which consists of intrinsic pathway, extrinsic pathway, and the common pathways. We also learned that the activated partial thromboplastin time, or the APTT, is representing intrinsic pathway. Prothrombin time, or PT, represent the extrinsic pathway, and thrombin time, or TT, represent the common pathway. But when we look at the entire hemostatic system, coagulation system is just a part of what we call the secondary hemostasis. And for the bleeding to stop, it requires both primary and secondary hemostatic systems. And secondary hemostatic system has not only coagulation system, but also has the cellular component, including the red blood cell and the platelet at the same time. Now, but standard coagulation lab test, or the SLT, it removes the cellular component during the test because the red cell and the platelets are spun out, and only the plasma is used during the test, and therefore removing the cellular component of the secondary hemostasis. So let's take a look at the PTT. The PTT was first described by the three pathologists in 1953. It is a test that developed to test for the hemophilia disease, and not until the Rappaport modified the test by using the kaolin instead of tissue thromboplastin that the test has been renamed to activated PTT, or APT, as we know every day. So as we can see that the APTT or PTT was created and developed to test and to follow up on hemophilia patient, and not for perioperative setting. Now let's take a look for another test of prothrombin time. The prothrombin time was first described by Dr. Armand Quick in 1934 and later modified by Arwen in 1959. So when the vitamin K antagonist, particularly dicumarol and coumarin, was first used in human in 1940s, then all the attention for the prothrombin time was to modify the test as a tool to monitor the effect of vitamin K antagonist. And therefore, the test has been heavily developed to use to monitor the effect of vitamin K antagonists and not to guide surgical bleeding and coagulation that happen in the surgery. And that's also raised the question, as say in this paper, that if the APTT is really related to clinical bleeding. This table, the author shows the most common indication for the PTT ordering, that ranging from the confirm and screening and of diagnosis of the coagulation factors deficiency until the last one is the ritual to waterway to put any potential hemorrhage. And not just that, The PTT itself could be interfered during the inflammation process, particularly during the surgery or after surgery, due to the C-reactive protein or CRP with a specific PTT reagent that's used in the test. And actually, this information has led to our CVICU system and the Stanford Hospital to have switched to the CRP insensitive PTT in our hospital. And thanks to the work by Dr. Jay Maddow from the cardiac and critical care team. Then let's take a look at the abnormal value of SLT. It also does not represent inadequate coagulation factor activity. As shown in this study that look at the several factor activity level in patient who was on Coumadin. And they test the different factor level as well as the INR value. The study found that most samples did not have factor level below 30%, not until the INR is more than 3.6. And what does it mean? Because in the normal human population, we only require about 20 to 30% of the coagulation factor activity to generate thrombin to form the blood clot. And this concept has been proved by this study, looking at the various factor level activity and coagulation test result during the liver transplant. And the study found that despite substantially prolonged PTT and APTT, thrombin generation, at least by the test, in patients undergoing liver transplant is equal or even superior to the healthy volunteers, and as we could expect, with adequate thrombin generation, blood will clot. Another proof of this concept is this study that published in 2012 by one of the medical students, looking at the effect of the pre-procedural prophylactic FFP transfusion tried to correct the abnormal coagulation test. The author found 88 prophylactic FFP transfusion, but only 30 of them actually had the post-transfusion lab follow-up. And within 30 patients, only 1 and 4 patients that the FFP transfusion actually had normalized the PT and APTT value. The most interesting finding from this study was 5 and 4 patients actually had increased PT and APTT value after FFP transfusion. So this study also showed that the prophylactic FFP transfusion does not reliably correct abnormal value of standard coagulation lab test or the SLT. And therefore, the author of this study aimed to look at the evidence of using the SLT in perioperative setting, as well as any evidence that to support the generally accepted goal of 1.5 time prolongation of coagulation test, aka INR or the PTT, as a cut point for the coagulopathy. The author found only 3 prospective trials with total of 108 patients that were useful and no randomized controlled trial to support the use of SLT in perioperative setting. The more interesting finding from this study was the author also analyzed 11 national guidelines in patient blood management. The author found that 6 out of 11 guidelines supported the use of 1.5 time prolongation of the coagulation test as a cut point for coagulopathy. But there are only 8 studies combined that were cited in these 6 guidelines. And there are 2 review articles without original data, another 1 expert panel, 2 retrospective observational study with only 3 prospective observational studies were used with total of 108 patients. And the author also found that these studies and national guidelines, actually they were cross-referencing each other a lot. Therefore, the author concluded that SLTs were not designed to guide perioperative coagulation therapy, has long turnaround time, and does not reflect compromised thrombin generation. There is a lack of evidence to support the SLT use in perioperative coagulation therapy guidance. And viscoelastic tests provide much quicker data and more comprehensive whole coagulation process. Now let's take a look. There are some limitations for the SLT. First, it has long turnaround time. It is difficult or if not impossible to detect hyperfibrinolysis or hypercoagulable state. It doesn't represent interaction of the RBC and the platelet in the clot formation. It does not reliably predict the thrombin generation. also lack the high quality evidence to support its use in perioperative setting. Viscoelastic test also has its own limitation. It's not as widespread as the SLT. It requires quality control and training outside the core lab. It's unable to detect primary hemostatic defect, and it's also not really practical to use during the active massive blood transfusion. So now we have learned about viscoelastic test, standard laboratory coagulation lab test, the advantages and the limitation of these tools. Now let's move on to how viscoelastic tests can be applied in the patient blood management in the clinical setting. Viscoelastic tests are used during perioperative setting for a long time. And there is meta-analysis looking at the comparison between the VET and the SLT in perioperative setting. Only RCT were included in this analysis. There were 21 studies included, 16 cardiac, 2 liver, 1 trauma, 1 auto, and 1 burn. The meta-analysis found that the VET utilization was associated with lower mortality rate, lower PRBC, FFP, and platelet transfusion rate, as well as had lower risk for acute kidney injury. Besides the efficacy of that, the author of another meta-analysis also analyzed the financial impact of that. And not only this study found reduction in PRBC, FFP, and platelet transfusion in the VET group, but also a cost saving in cardiac and trauma patient compared to the SLT. And not so surprising, VET has been extremely studied in the field of cardiac surgery and has been widely adopted in several national guidelines in cardiac surgery. For example, this one guideline that published in 2021 by STS, SCA, AMSEC, and SABM in the patient blood management. The guideline advocated for a point-of-care testing such as viscoelastic test to guide transfusion algorithm during cardiac surgery. And it gave this recommendation a class 1 recommendation. Society of Cardiovascular Anesthesiologists also published its own guideline in 2019. And the guideline recommended the transfusion algorithm that based on the based on the point-of-care coagulation test. And the transfusion management based on viscoelastic test can reduce transfusion-associated adverse events. The working group stated thus, it is a working group opinion that viscoelastic coagulation tests are superior to conventional coagulation laboratory study in guiding transfusion therapy in patients undergoing cardiovascular surgical procedure. It also published the recommendation for the algorithm of how to utilize the take and rotem value in guiding blood transfusion based on the value of the test and its variation. And let me show you this one. It is for the work of our own pediatric cardiac anesthesia colleague led by Drs. Jumbo Williams, Manshula Navaratham, and Alex Schmidt. They have developed and implemented the transfusion algorithm in pediatric cardiac surgery, which is largely based on the viscoelastic test as a standard of care in LPCH. Also, there is an ongoing study by Dr. Schmidt still looking at utility of the Quanta system compared to the tech for congenital cardiac surgery at LPCH right now. So we can see that viscoelastic test has gained a significant role in patient blood management in both adult and pediatric cardiac surgery. Now let's move on to the trauma surgery. Trauma patient can often has a condition called trauma-induced coagulopathy or TIC. And the TIC is not as simple as patient just losing blood, coagulation factor, and the platelet and patient just bleeds. It's a complex process that involves many systems and also many mechanisms involved. So the trauma-induced coagulopathy, patient will develop, patient who bleeding will develop consumptive coagulopathy, then shock developed, and lead to resuscitative coagulopathy by hypothermia, acidosis, dilutional coagulopathy, and so on. Even that, tissue trauma can also cause endothelial activation and increase the TPA, activated protein C, and plasma activator inhibitor or PAI-1 activity, which can lead to the platelet dysfunction and hyperfibrinolysis. And things goes on and on and on in trauma patient. Therefore, it is very important for the early detection and prevention of the trauma-induced coagulopathy as a treatment. And that includes timely diagnosis, accurate diagnosis, and diagnosis that actually cover the broad-based cause of coagulation defect, including hyperfibrinolysis. And the test that can actually be an early predictor of morbidity and mortality after the trauma surgery. And viscoelastic test hits all the points. Because not all coagulation factors are affected equally during massive blood transfusion. And it is hard to predict from the amount of the estimated blood loss. Plus, the median time from exsanguination to death is about 120 minutes, while the SLT turnaround time, average time, is about 60 minutes. So therefore, making the SLT is not the ideal test to detect coagulation factor in the major trauma surgery. However, viscoelastic test may be one of the best options during the major trauma because it looks at the whole entire coagulation process instead of each pathway and can detect the broad-based causes of coagulopathy, as well as it have a shorter turnaround time. And not just that, viscoelastic test result can also be a prognostic factor for the mortality in trauma patient. At this study, found that the higher fibrinogen contribution to the maximum clot strength during the admission predicted the lower mortality rate after major trauma surgery. Therefore, there are several proposals by the several group on how to use viscoelastic test to guide the blood transfusion in trauma patient. Now, we're going to move on to obstetric hemorrhage. But first of all, I would like to thank Alex Budwick, who is now on very nice vacation that he deserves, for talking to me about how viscoelastic elastic test has been utilized in the labor and delivery rooms. So there are some evidence shows the benefit of the VET in obstetric patient, as is shown in this retrospective study in 86 postpartum hemorrhage patients from over 20,000 delivery. The author found that a patient who managed with the viscoelastic test received less PRBC, FFP, and platelet transfusion. And not just that, the viscoelastic test group also experienced lower incidence of the hysterectomy, lower EBL, and had a shorter ICU length of stay compared to the non-vet group. Oh, sorry, I thought someone wanted to chime in. Also, Dr. Budwick also published this article on how to manage patients with a severe postpartum hemorrhage in the Transfusion Journal in 2020. So he proposed the transfusion algorithm that based on both TEG and the SLT. So let's blow it up a little bit. So he proposed that we send both SLT, CBC coagulation test and the TEG or viscoelastic test, but he proposed to use the R time from the TEG as an indicator how to transfuse, as a guide how to transfuse fresh frozen plasma, and also proposed to use the MA or maximum amplitude as a guide for the platelet transfusion. Another important application for coagulation testing in obstetric patients is to determine any contraindication for neuraxial block. That said, the most recent published guideline in 2021 did not find sufficient evidence to support the use of viscoelastic tests to determine the eligibility of neuraxial anesthesia. In the conclusion, we see a rapid development of the role and the utilization of viscoelastic tests in obstetric population. However, the further study is still needed, and the traditional massive transfusion protocol is still supported in response to obstetric hemorrhage. So we'll move on to the next one. So despite the paucity of evidence, the viscoelastic test has shown some potential benefit in neurosurgery. There are several strong evidence showing the benefit of viscoelastic testing in neurospine surgery, such as this prospective study showing in high-risk spine surgery, the ROTEM-guided blood management group has reduced PRBC and FFP transfusion compared to non-ROTEM group. Another study also shows significant potential cost saving between $1,800 to $7,200 per case by utilizing ROTEM-guided transfusion therapy in complex spine surgery. This one is another benefit of viscoelastic test, that we usually look for coagulopathy, but not hypercoagulable state. This study is highlighted the importance of viscoelastic test ability to diagnose hypercoagulable state. The hypercoagulable state is a risk factor for a delayed cerebral infarction after cerebral ischemia after subarachnoid hemorrhage. As this study showed that the higher take MA value in subarachnoid hemorrhage patient is actually associated with poorer outcomes. So now here come to my last slide for today. So in the patient blood management field, any guidelines and algorithm outcome are as good as the quality of the data is used. So high quality data should be accurate, complete, relevant, valid, timely, and consistent. Viscoelastic test can provide a high quality data about the coagulation status and can improve the outcomes in patient blood management. Thank you for your attention. Any questions or comments? That's a really good question, and I think that's one of the things that I think we should strive for it. So right now we can send a tag, but we cannot look at the waveform in the real time, which actually counteracting the benefit of point of care testing for the viscoelastic test. The caveat about this is the viscoelastic test right now is being done in the central lab right now, and the screen that clinical lab shows us requires separate login. So that's more like the IT system that we should actually be able to access that for all of us to, to improve and utilize the most out of the viscoelastic test that we sent. Yes.
Great talk. Thank you. Are there any applications for AI in this? So like if you run a test, it would be like a recommendation based off like an internal built code or something like that?
AI, you mean the artificial intelligence?
Yeah.
So I think there are, however, as far as I can see, viscoelastic testing is still relatively new because particularly with the launch of the ROTEM and push for more variation of testing, there are a lot more data that started to look on non-traditional parameters, like for example, the maximum amplitude of the various timing. Instead of 5 minutes, 10 minutes, now we are talking about 12 minutes, we are talking about so on. So I think there's also a role for that for sure, but I think we just need more information and the data, particularly comparing to the conventional coagulation testing. Yes. Yes.
Can you comment a little bit about the evolution of the viscoelastic testing systems? For example, like Stanford is currently using the Tech 5 system, but now the Tech 6 is available. What advantages does the new system provide over some of the older generations?
So the older generation is just one tech graph that's activated by Kaelin. We also have the test that added heparinase to get rid of the effect of heparin at the hospital. So the benefit of adding those variation of the newer system is adding more activators and also inhibitors. For example, not just only added heparinase right now, so we can actually looking at the pure fibrinogen contribution to the maximum amplitude. Fibrinogens right now, turnaround time is about an hour. So in maybe not that so long ago, about maybe 6 months ago, when we still use the regular cryoprecipitate, that means that you waited for an hour to get the fibrinogen level back and then decided when to call for the cryoprecipitate. And that takes about 45 minutes to thaw. So total, we're counting about 2 hours turnover time before when we send for the labs and get the cryoprecipitate. However, with the new system that could be point of care testing and also has a functional fibrinogen level, it will give you the idea of the fibrinogen level within 10 minutes. And that also shortened turnaround time. There's actually a study comparing between two pathways, and the result showed that it saved about an hour from the time we send the test to the time of the treatment. So that's the benefit of the newer system, where there are a lot more variations, a lot more testing, and we can obtain more data compared to the traditional tech system that we are using right now. Yes.
I want to hear your comment on the use of the standard lab test or send out, so to speak,